Hi, I'm Dr. Ludwig Lin, and welcome to the Vital Times podcast for the California Society of Anesthesiologists. Today, I and our guest panel reflect on the impact of the recent shifts in healthcare delivery and funding on the operations of academic anesthesiology departments. How has a modern-day anesthesia department chair had to evolve and adapt as the needs for anesthetic locations increase, research funding decrease, while the cost of operations and living skyrocket in California? I specifically wanted to speak with California-based anesthesia department chairs who had been in position during this period of change. Dr. Ron Pearl recently retired as the Stanford chair. He completed medical school with MD PhD degrees from the University of Chicago, and then completed medicine and anesthesia residencies, as well as a critical care fellowship at Stanford. He served as the anesthesia department chair at Stanford from 1999 through 2021, and has served as the president of the Society of Critical Care Anesthesiologists, Society of Academic Associations of Anesthesiology and Pain Medicine, and the California Society of Anesthesiologists. Dr. Michael Gropper has been the UC San Francisco department chair for 8 years. He graduated from UCLA Medical School with MD PhD degrees and trained in internship, residency, and critical care medicine fellowship at UCSF. He transitioned from being the chief of critical care medicine to being chair and has focused on both research and critical care medicine. Dr. Richard Applegate is currently the endowed chair of anesthesiology at Loma Linda University. Prior to that, he was the chair at UC Davis from 2016 to 2023. I feel like we're getting 4 different experiences in this conversation because of that. Dr. Applegate completed medical school and residency at Loma Linda, completed a fellowship at Mayo Clinic Rochester, then did a year of private practice prior to joining the faculty at Loma Linda. His clinical and research focus is on improving outcomes following surgical and other injuries. Thank you all for taking the time out of your very busy schedules to have this conversation. It's going to be very, very illuminating for the CSA membership, I think, to hear about your experiences and thoughts. So I really treasure this opportunity. I'm going to start out with a pretty broad topic, and feel free to just jump in. And the question is, how has the priority list changed for an academic anesthesia chair over the last 10 years? We'll start with Dr. Pearl. How about that?
Yes. So one thing I would emphasize about how the role of department chair has changed has been the incredible growth in the size of academic anesthesia departments. It used to be that the chair knew every faculty member, met with them frequently, and was really the main person that faculty looked up to. But as departments have grown, we have now about 300 faculty members. That's just not possible. So the role of the chair has become more of a organizational leadership role rather than a lot of direct supervision, mentorship, etc., which really changes the relationship. And as a result of that, much more delegation of responsibility to division chiefs or directors, etc. The second piece of it has been with that great expansion. What allows departments to function is the clinical revenue and their relationship with the hospital, because and I'm sure we'll talk more about the ongoing workforce shortage, academic departments are very much dependent upon support from the institutions, and a lot of that comes from the clinical revenue. The clinical enterprise has dramatically grown, and so a lot of department chair responsibilities are being sure that the clinical enterprise of anesthesiology, whether that's the operating room, the pain clinic, the ICU, labor and delivery, functions effectively. So much more of a role in really the practice management side than previously, where department chairs were very much more able to focus on a lot of academic aspects.
Dr. Gropper?
Yeah, I mean, I think Ron's described it well. I reflect back to one of my mentors, Ron Miller, talking about he was very proud that the department was completely independent of any support from the health system or the medical school, and that gave us independence to focus our efforts where we wanted. And of course, every department now is in a deep partnership with the health system. As in part because salaries have increased so much that we need to provide that service at as close as we can get to a market rate, which is going to require health system support. And so when I think about my job now, it is, I would love to be much more involved myself in research and academics, but really my job is to make sure that we have the resources that we need so that it can support other people from doing those academic things. Just like at Stanford, and I'm sure Loma Linda, we've tripled in size since I finished my training. And I agree, I don't know all the faculty necessarily. I was joking with someone yesterday, we give everybody, faculty, residents, staff, these sort of brightly colored lanyards to hold their ID badge so that when they're coming at me down the hallway, when I see one of those, I always say, "Hey, how you doing?" Even though I probably don't have any idea who they are. It seems to work. I'm just terrified that those are going to be spread to other departments or something. But it's a very different job, and in particular, the growth that we're all experiencing as health systems, academic health systems are becoming enormous entities, and that's exactly what I hear from my colleagues all around the country is that health systems are buying up hospitals in their areas, particularly community hospitals, opening ambulatory surgery centers. And so that's really where our focus has to be. And you really have to think carefully about your vice chairs and division chiefs. You can't possibly do it all on your own, and you have to empower them to be involved in a lot of these things. So in some ways, I miss the really intense academic focus that we had, and I'm still trying to do that. But if you look at the average person, anesthesiologist that's hired in the department, they are less academic than they used to be because there's so much. The demand is for clinical coverage, and that demand is much greater than the demand to have more research productivity. We'd love to have it, but we're hiring people a little less research focused. We can't afford to let any of our residents or fellows go elsewhere, even if they really aren't interested in a research career or education career. We need to keep them because that's the best source of providers that we have.
I think Ron and Michael have actually summarized it well. I'm going to pivot just a little to say that coming up and growing up, watching departments across the state and country, you had the triple threat. A chair always had to be able to balance a budget, but honestly, in an era when the payer mix was so much better and the match of resources to demands was so much closer, you really had the triple threat. They were the leading academician. They were the clinician everybody wanted to be like, and they could teach like nobody's business. And, you've got examples there. My colleagues here on the screen are perfect examples of that. But as stated, our job has pivoted and shifted. Anesthesia is considered an essential cost of doing business or a service. It's not. We are foundational to the success of every other department in an academic center, even pathology, because their margin comes from surge path, which doesn't happen without surgery, which doesn't happen without us. Radiology is a lot of interventional now. That's where they generate. Most health systems, 60, 65%, even higher, of the positive margin is out of procedural work, most of which needs an anesthetic. So we are now foundational partners. And there is, as already stated, you can't do it on professional fee collections anymore with as many places as they want us to cover for as many hours as they want us to cover those. You have to be in partnership. So I think that the role of the chair has shifted to much, unfortunately, more of at least financial awareness, if not fiduciary responsibility. You have to be in step and in agreement with both strategy and tactics to achieve the health system goals, or they find somebody who can. So it is disappointing. I really, I always wanted to be, and Ron, I know I've told you this, he's my hero because he survived his chair for over 20 years, a remarkable feat, but was able to maintain that quadruple threat balance that is very hard to attain and to maintain in the current environment. We're all fighting the same things. You've already heard it. Inflationary incomes in the area. My trainees are being offered, first year incomes that are breathtaking, that I can't come close to matching. And yet, as Michael noted, you can't really promise everybody in academic you're going to have 20, 30, 40, 50% research time, because I can't cover everything if you're out doing that and you don't have grant funding yet. I can't do both for a brand new hire. So it's a much different job in that regard from what I observed growing up and then my first few years up at UC. So it definitely has shifted over the last decade, I would say. Maybe a little longer. Ron's got a better perspective on that.
Yeah, no, I want to add another comment, which we've talked, all of us here, about. We're now part of a healthcare system. The role of the anesthesiology chair was really to focus on the anesthesia department. Now, a major aspect to be an effective anesthesia chair is you have to become a healthcare system leader and move from focusing on your role as an anesthesiologist to really playing a major role in healthcare system strategy, decision-making, the collaboration to make the entire enterprise run well and be profitable. Mm-hmm. And there's a lot of enjoyment in doing that at that level.
There are so many directions I want to take this conversation, so I'll just go bit by bit. That was a great way to really lay the foundation for this conversation. Before I go forwards in discussion, maybe I can get you to educate me on something historic. So for somebody naive like me, it sounds like there was a time when the anesthesia departments were able to be financially, quote unquote, more self-sufficient or independent, whereas now it requires more subsidies from the healthcare system or the university just to be competitive in terms of the remuneration for the faculty. Is that true? Is it not true? And how did our healthcare environment evolve to necessitate that?
I don't know who wants to go first on this one.
We'll just always start the way we answer the first question. How about that? So we'll start with Dr. Pearl.
Perfect.
Okay, let me first emphasize that this is not simply an issue for academic anesthesia programs. Now, this is a problem for all of anesthesiology. What has happened is that reimbursement in many ways has declined. We talk often about the Medicare, 33% problem. Now it's down in the mid-20s. Issue in terms of the reimbursement we get. We have more Medicare patients. In California, we have Medi-Cal, which pays even less than Medicare does. The cost of providing anesthesia has skyrocketed. That's part of our increased compensation. And in the past 4 or 5 years, the anesthesiology workforce shortage has made that even more severe. And for practices in general, the amount of revenue we get from providing anesthesia just is not sufficient for what anesthesiologists currently want to get paid. Some of that has to do with inefficiency. The expansion of NORA, non-operating room anesthesiology, spreads us out in ways where we don't go from case to case to case, but we're often waiting for proceduralists. There is often in many places scheduling of the operating room, which is for the surgeon's preference, and we may have multiple rooms as opposed to one room that continues all day. So the revenue is just not sufficient for the cost. It's a major problem, and now we're having to, as there's a shortage, everyone is trying to hire from everyone else, and in particular, private practice very much is hiring people who otherwise would have joined or stayed here, and it means we have to increase what we're spending. So the only way of making that work is to have additional sources of funding, and that the institution your healthcare system, your hospital, etc., is where all that money in the end has been coming from nowadays. And as department chairs, we all are very concerned because at some point it's not going to continue this way. Hospitals in many places are no longer having the profit to be able to support anesthesiology as they are right now.
Yeah, I think Ron is, again, well described, particularly on the payer side. I think the other piece is the expectations of the people that we're hiring. So going back to many years ago, when people that came into academic departments knew well that they would make less than their private practice counterparts because they were entering really different jobs. But as I said, many of the people we're hiring now, we're hiring to function very much like a private practice anesthesiologist, 4 to 5 days a week, providing clinical care, much less exposure perhaps to the academic fruits of our jobs. And so if you're going to be able to hire those people, you're going to have to offer a competitive salary. At the same time, they're very different. Their expectations as the generations have changed, and we now had been hiring millennials and Gen Z. Their expectations of their work and their life are different. It means you probably need more people to staff the same number, a given number of locations. There's much more, for example, sharing of childcare, childbearing leave, et cetera. So their expectations are different. They're coming out with record amounts of debt from medical school and residency that just can't be ignored anymore. So we have to, and then at the same time that as the demands of the health system are increasing, we just have to be able to appeal to a much broader group of people than perhaps when all of us joined our academic jobs. And so that's part of the problem. I guess the other thing I would say is the extraordinary growth of NORA, as Ron mentioned. And then also we're all busy transplant centers. There's so much more work in the middle of the night than there used to be. And that also then means you really need more people. If I'm on cardiac call tonight, probably at all our places, we have a 50, 60% chance of having to come in, work 4 to 6 hours. It means I can't work all day today if I'm on call tonight, and I can't work all day tomorrow if I was on call last night. We need a lot of people to provide these services. And so that also has been a challenge. So all of those things go back to needing health system support. I suspect that the three of us spend really a lot of time educating health system leaders on what it is that we do, because trust me, they're not in the hospital in the middle of the night. They have no clue. And so we have to, done a lot of work, and it's relationship building and understanding that they know it's a very expensive resource, but I think, and they grudgingly support it often. But I'd rather it not be grudgingly. They do it because they know they have to. None of us want to get to the point where we say, well, if you don't do this, we're not going to be able to run as many, 3 transplants simultaneously in the middle of the night or whatever it is. But that's a big part of what we have to do. So there are just so many changes around not only the work that we do, but also the expectations of the people that we're hiring.
And although I don't want to just say what they just said, I'll put a little different spin on it, but I couldn't agree more. The dilemma that we face is twofold. One is not that there is work to do, but there's an expectation that if I've agreed to cover transplants, plural, if I've agreed to cover non-OR anesthesia locations, if I've agreed to cover 52 starts in one building, I have to have the person there whether there's work or not. This is very different. We are in many ways captive to our health systems and our anesthetizing locations. We really can't just say, hey, you know what? There's an operating room, and there is one literally 3 miles from here that'd be happy to have us come over and take cases. But if I do that, that means I'm pulling somebody from here, which means my administrator says, wait a minute, why are you hurting me to go make more money somewhere else? We're different from the surgeons in that regard. Very different from the surgeons. And I think that part of it is the twofold thing. One is as mentioned, really remarkable increase in incomes. And if you look, little blurbs, but anesthesiology incomes on average across the country have gone from 337 to 448,000 over the last year. My trainees are being recruited to places that are paying 50 to 100%, promising 50 to 100% more than that. They do not mention how many hours you're going to work to get that income. But again, when you come out with $500,000 of college and medical school debt, those big numbers look really, really appealing. So we don't argue with our administrators. I know all of us have the same approach. We educate. We then substantiate. We bring them the data and we show it to them. And then we negotiate. We never argue with them, but we educate, substantiate, and negotiate, because otherwise you can't. You can't stay. And I will say that a lot of the places that are offering these, high hundred thousands, I mean, we're talking about people being offered first year potentials of 600, 800, even 900,000 in their first year out. They're also getting call support from their hospitals. They're getting OB coverage agreement support from their hospitals and so on. So this is now not just limited to academics. Where we are further disadvantaged, it really depends. And each of us have slightly different health systems and hospitals that operate slightly differently. Although we are not the county hospital down here in San Bernardino County, and therefore do not get the guaranteed funding from the county that the county hospital gets, we have an absolute disproportionate share of Medicaid, Medi-Cal patients. Our children's practice, and I'm sure it's probably true at Benioff. I'm not sure if it is at Packard, but 75, 80% are on Medi-Cal or managed Medi-Cal here in our pediatric population. You cannot pay what anesthesiologists are making on average, let alone what the private practices are offering on that payer mix. So our blended reimbursement is, a third of some of the surrounding practices. So that makes it very hard for us to recruit. We cannot do it without. And that's why our jobs have shifted to really being part of healthcare system leadership, as Ron mentioned. We spend, and Michael, we spend a lot of time talking with our administrators, trying to help them understand that, not only anesthesia, if we have a day where 50% is productive in terms of anesthesia billing, that's a good day for Nora, right? Because you're going from scanner to scanner, from suite to suite, hoping that the scheduling was perfect. It almost never is. So there are a lot of downtime, but again, I'm mandated to cover it. So these are the reasons why. It's that combination. And, it's hard. It's very hard to retain our trainees when they're getting those kind of offers. So med schools are trying to get clever and offer, if you're willing to stay, we're going to have a year for year or a 2 year for 1 year payback on your medical school debt. The ones that have bigger endowments are offering tuition free scholarship support to some of their students, if not all, depending on where you are in the country and so on. This is going to be a very big long-term issue for getting physicians trained.
Yeah, let me add one more comment on this, which is the impact of having to go to the hospital for support, because otherwise you're losing money, on what happens to the academic research and to a certain extent the education program. Hospitals can understand that if you're losing money because your clinical activity is negative profitability, yes, they need to make that up. That's their responsibility. But they don't necessarily, in many places, believe their responsibility is to support your academic program. And that is affecting many academic departments throughout California and the country.
Yeah, that they view that as the School of Medicine's or the department's job to go out and get the grant funding from somewhere else.
I want to talk about both of the themes that are emerging. One is the changing tasks that are involved in being a chair, and also about perhaps the changing mission statement for the chairs. Let's go with the tasks first, because I feel like that's what we're talking about right now. When I'm hearing you three talk, it's so clear that the skills that you need now are very different from when I was a medical student and resident and hoping to be in an academic department, where it's all about research, it's about being a good clinical educator, being good at what I do, basically, and maybe being a good administrative leader. Now, there's all these financial implications and personnel management. And for people who are the chairs, as you three are, it sounds like you have to be very nimble. You have to be very aware of all these higher level factors involved in the hospital administration. How have you three had throughout your careers had to change your mix of skills, and how on earth did you go about acquiring those? That's just my own personal curiosity. We'll start with Dr. Pearl again.
So I think there's much more emphasis now on some of these other skills that you still need to have the leadership ability, but you need to have more management. And so the large majority of people now who are becoming department chairs have MBA or some other type of both financial and leadership training for part of it. It also gives them the same language as the hospital leaders that they're going to be speaking to, who are not medically focused but are much more business focused. With that comes it's now impossible to run an anesthesia department focusing only on anesthesia, and the ability to have really those soft skills of collaboration, forming relationships quickly, knowing how to negotiate with people, become really essential to doing the job. There still, I think, is an emphasis on in academic institutions, you're being hired to have an academic anesthesia department, and the ability to understand how research functions, how to mentor people, how to recruit becomes a continued requirement for that. So I don't know that the skills have actually changed all that much over time, but the relative importance of different skills has become significant. The other aspect, as we mentioned, is it's impossible for a chair to do all of this in the department. So again, organizational skills become important. And what chairs need to end up doing in general is to figure out areas where you may not have really that skill, of finding a vice chair who will do that, whether that's someone who's going to run the operating room, someone who's going to be your vice chair for research, someone who will deal with business issues, someone who will deal with the education program. You sort of have to be over all of those. You can be an expert in one or two of them, but you certainly are going to need to be recruiting and knowing how to really manage and supervise the people who you're asking to run those different missions of the department.
Yeah, I think maybe the three of us are a little bit more transitional chairs to what the modern chair is going to be like. It used to be pretty much a requirement that you were, or at least were or used to be an NIH-funded researcher. That's what deans were looking for in chairs. And that is nice, but and maybe some of those skills are important. How did you get a grant, the critical analysis? But yeah, I think the modern chair, when I look at particularly some of my younger colleagues that are chairs, they're mostly either have or are obtaining MBAs. I think that's important. I, wasn't sure I wanted to do that, but like Ron, rely on others who do have that kind of training. And increasingly, I think, as we become, if I look at, new positions that I've added since I've been chair, a vice chair for well-being, a vice chair for DEI, a vice chair for community practice, right, which was not even a thing. So, I think and then, my critical role, I like to think about what is the one thing that only I can do, and that is to be in the room with the health system board leadership, be on every critical committee with them, to be the face of anesthesia while having experts in research and education, clinical, et cetera. So I think that's a big change, and so that skill set of how are you effective in the room with the health system and leadership, and secondarily with the School of Medicine, depending on how you're structured, you have to have that skill set of communication. And being able to choose good people as your vice chairs and leaders. But again, as departments have 5, 6, 7, 800 people in them, You have to really, you need to be there. You can't say, oh, I can't make the next funds flow discussion because I'm going to be on call in the OR. That's not acceptable. I have a lot of people that can be really good anesthesiologists on call in the OR. I love doing it, don't get me wrong, but there's no one else that can be in the room for that key discussion, and you have to recognize that. And I, on occasion, will see colleagues, not necessarily in anesthesia, but in other departments, that miss those discussions because they have something they think is a higher priority. And I will say that's one of the first signs that they may not succeed as chair. A piece of advice that I got from our outgoing radiology chair, who was sort of legendary, Ron Aronson, when I became chair, which is kind of my mantra, which is, the faculty don't work for me, I work for the faculty. And that is, if there's one thing that you think about as what you do, it's just that, which is how do I enable everyone else to be successful? And if I do that, I will be successful, of course. It's not that I don't, have any ego in it, but I often see that as a mistake that particularly some new chairs can make.
I think that's really well stated. And I like your term, Michael, the transitional period here as anesthesiology chairs, because we really are. We're switching from, the academic research clinician, teacher, expert to, unfortunately, or just in reality, increasingly system-based, operationally focused. And if you do look at the new chair hires, many of them are coming out of operations backgrounds, not research backgrounds, right? And I think, the way you learn it, it's different for each of us. I had a good environment and worked my way up the ladder, got to do each of the various different jobs in the department, got more and more involved with running. I was actually director of perioperative services, medical director of the perioperative services for a while. You learn all of these things. I had good mentors in finance. I didn't ever bother to get a finance degree, but I had good mentors in finance. What's hardest for a chair, I think, is this. As anesthesiologists, let's face it, we do it ourselves. I make a decision. I order myself to dispense the medication, administer that, and then take care of anything else that happens. We do it all. You can't. You have to delegate as chair, and you have to get comfortable with the idea that sometimes your vice chair may not have understood what you thought was the vision and the direction we needed to go. But you have to trust that you pick good people and delegate some of these things, because it's so important. And Michael said it perfectly. You have to be at that table so that you don't end up on the table. You just have to be. And sometimes your faculty don't understand what you're doing. A lot of what we do is not visible to the people that consider themselves the boots on the ground in the trenches doing the cases, the ones on night call for all of that trauma and transplant. They don't understand what you're spending your time doing as chair, behind the doors, talking to the administrators, educating them about what needs to be done, and so on. So communication becomes important too. You have to let them know that, in fact, I am working for you. A good example I had, we had some very intense education and negotiation over base salary. We were failing in the recruiting market. And the discussions were very tense. And you cannot afford to have an open telegraph of, hey, these are all the things that we're talking about, and this is what that administrator said, because that cements people into their position. And you'll never get them to move towards where you need them to be if they get backed into a corner by all your faculty demanding that they want this first offer, right? So a lot of what we have to do is behind doors. It has to be kept quiet until you reach a point that everybody agrees that you can now share the information. And your faculty can get frustrated with that. They think you're not doing anything for all that time you get out of the OR or the ICU. We're busy, but a lot of it has to be kept invisible until it's time to make the big announcement. So that's a different skill set that you have to learn over time, I think. I'm not even sure that the education courses teach you to do that. That's all about relationship building, having credibility, and making sure the people on the other side of the table do know that you're actually very expert at the things that you are doing for your department and for the system. Again, we have to be system-based thinkers or we fail.
Yeah, I think also that what I underestimated, or have learned at least, is the importance of communication. I think we all really hit it, in the pandemic, but, as we become more dispersed and larger, you have to make sure that everybody understands what it is that you're doing, because things can, have rumors and take on a life of their own. The communication piece is huge. It's not easy. And, scale gives you some opportunity. I've now invested in a full-time communications director, which has been fantastic. And she, again, going back to the transitional piece, the average person in my department is significantly younger than I am. And they expect communication in different ways. They want to use Slack and they use social media, et cetera. But it's also, what is the messaging of what you're trying to do? Because people will start to think that, we've just bought two new hospitals in San Francisco, and then all of a sudden it's like, oh, we're all going to be forced to go over there. That's not true. It has zero truth to it. But people will convince themselves that something bad is going to happen. And so learning how to communicate is really important, and actually leaning on people who are experts in communication, I think, as well.
If I can just say,
yes,
one quick comment. The great thing, and Michael just reminded me of it, one of the great things is the communication among the chairs. So here, our California chairs, we have an email group. Our Western Region anesthesiology academic chairs have an email group. And we ask each other questions frequently across this email chain. Hey, what are you doing about? Somebody asked me for, how have you been approaching? And sharing that knowledge among the chairs, it's probably kept me from going crazy a couple of times at least, being able to hear that, no, I'm not the only one facing this issue. I'm not the only one whose faculty think I'm insane. This is actually a really helpful thing for us, I would say, is this collegiality among the chairs across, again, the Western region, certainly nationwide, but here in the Western region, we face fairly similar challenges between the states. So it's been very helpful for me anyway. And I think everybody has asked at least one time where they're facing something insane, and the rest of the chairs say, yeah, this is our version of that. So I think that's been helpful. I can't afford a communication director yet, Michael. I wish I could, but I can't yet.
I wanted to follow up on this. So Michael was talking about the importance of communication and delivering the message to the faculty. So for all three of you, what were some of the successful strategies for doing that?
So, one needs to be constantly communicating. Much of that's either going to be through one-on-one meetings with the faculty member, through meeting with small groups, whether that's members of a division, junior faculty versus senior faculty, clinically focused faculty versus research faculty, through email communication, through annual bulletins or whatever. You basically never over communicate. It's important that faculty members have both trust in you and feel that they have some relationship with the department chair. That's a lot of what they're expecting, what keeps them there. They are always thinking about, why do I stay at this institution rather than go to another academic institution or go into private practice? And communication is playing a very critical role. For me, when I began, there was a monthly newsletter. During COVID times, there was lots of anxiety, and I wrote very, very frequently to keep people updated, to let them know what we were doing. Met annually with every faculty member until we got so large that was not possible, and then tried to periodically meet, had lunch with groups of faculty members. Our current chair has open office hours where people can stop by and talk, and a sense of openness is really important. It's you want the faculty to know that you are working for them and that you care about their careers. They nowadays everyone wants to not simply be a anesthesiologist in the operating room. They want to see career development, have leadership roles, whether that's at your institution, society, in other ways. They have interests that they want to pursue: global health, DEI, education, and you're critical for them feeling that they can achieve that. And so you want to communicate with them. It is amazing to me as a chair how when I meet with individual faculty, they would tell me about really the struggles they have in their personal life, whether that's health issues, family issues, relationship issues, and you really do want to be seen as someone they can come to and trust. In many ways, I would say that the best training I ever got for being a chair was being a psychology major in college and getting whatever insight one does into really how people view what's going on. I'd say some of that was also learning about the aberrant psychology that some faculty can sometimes have as well. But communication is you can't do too much of it.
Mm-hmm. Yeah, I think it's hard. I mean, trying to hit the sweet spot. For example, having a faculty meeting from 5 to 6 p.m. There's a lot of resentment for that. I get that. So we moved. We have faculty meetings on and actually the traditional once a month faculty meeting where everybody was in one room is actually outdated. When we're spread to 6, 7 campuses, it's going to be by Zoom, and that's fair enough. When to do that so that it's not viewed as inconvenient. It's not you're able to, if do you need childcare to be able to do that? You have to think about that. I agree with Ron. Bringing resources to the faculty. So I had open office hours, but they were pretty lightly attended. And so then what I've gone to is what's called Gather with Gropper. I go to each campus every month and sit in a conference room right next to the ORs with a whole bunch of boxed lunches. And that's actually worked pretty, between 11 and 1 or 2. And that works pretty well. Now, do some people just come in and grab the lunch and leave? Sure, fair enough. But you know what? They saw me. I was there. They had a chance to say something. It's hard, doing it by Zoom for sure is less desirable, but it's just pragmatic. And I'll give an example. Before the pandemic, our research conferences were in person, and we had, good attendance, 20 people, 25 people. And of course, we couldn't have that during the pandemic. And so we went to Zoom, and the attendance almost tripled by Zoom. So it showed you that, the activation energy of driving at least across San Francisco and trying to find parking is just too high, given, perhaps it's a topic that, you're kind of interested in, but maybe not. But, whether it's that or the faculty meetings, having them on Zoom has greatly increased the participation. I wouldn't say that it's the same quality of participation, but part of it is, people have the opportunity. And and Ron's right. I mean, I think being a psychologist is helpful. For example, at every faculty meeting, I'm very transparent about the department's finances. How are we doing? What's our income? What are our expenses? Here it is. I don't send that around. I'd rather the health system or others don't see it. There's a chance that they would, and it's okay. And then you'll hear that, in a survey or something where people say, well, there's no transparency around finances. Mm-hmm. There's actually complete transparency, but those are people that don't, log into the Zoom or go to the faculty meeting. So that's one piece. And then the other is what we've started to do is build some internal coaching resources. Coaching, I still have a coach every month. It's extremely valuable, but it's valuable and it's expensive. We couldn't possibly offer that to all the faculty. So I have now 4 faculty that I've supported to go to get some kind of coaching certificate. I don't know exactly what it is. But then they can each coach 6 or 8 people. And so we're going to continue to build that program so that you can bring that kind of faculty development and career coaching as an internal resource. But it's a challenge as we're all spread around.
Yeah, and I would agree. And it's funny, when I took on the job at UC Davis, one of the first things I talked about was the opportunities we had since we're spread out. We could use electronic equivalents to having meetings in person. And it was as though I was speaking into a void. Nobody really picked up the idea that, that could work, because we're so used to meeting in person. Clearly, several things triggered changes. Pandemic is the most obvious one. But we underwent, in my first year and a half there, we had 3 different strikes by the major unions. This is a very big deal for a department that's focused on covering anesthetics when your surge techs or your nurses or the other staff that support operative care are on strike. So we started daily meetings that you could dial into by telephone. Then the pandemic hit. in the panic stage when, there were a lot of, it reminded me very much of the onset of the HIV/AIDS epidemic, in that people really were afraid they not only were going to get it, but worse, were going to take it home and have their loved ones, their children's grandparents, their children, their spouse get this horrible thing that we didn't really understand yet. So we actually went to initially morning and afternoon faculty town halls, which we started holding over Zoom. We then went to 5 days a week, and then we were able to go to 3 days a week. But over all of that time, anybody who wanted to could dial in. Now, I will admit, there are many faculty. I love it, Michael. That's a perfect example. Transparency. Revised the compensation system and literally went through line by line. What does this mean? How do you earn this? How do you get this? Line by line. Faculty meeting on, both in person and on Zoom. And a lot of people, phone is attending the meeting, and then at the next faculty meeting complained that there's no transparency. Why are we getting paid this way? We literally went through line by line. So there is a difference in person and Zoom. In person, I have a little bit better hope of telling if you're really listening or if you're distracted. On Zoom, cameras are off. You have no idea. Maybe they're playing with their kids because, a lot of this stuff does have to happen after operating hours. Well, scheduled operating hours. We never stop operating. But I think that you have to communicate. You have to be visible. Great examples have already been given. You have to be trustworthy. Ron's examples are beautiful. But you also have to, and in addition, and I know we all are, but you also have to be discreet. So if somebody tells you something that leaks from your office, your credibility takes a huge dive, and it takes a very long time to rebuild that trust. I have heard things from faculty that stay here in this office, and 6 months later, somebody will come out and say, wow, I heard that doctor, and didn't come from me. And these are, life events that are great for the people, even simple things. Women faculty are going to have babies. This is really exciting, but it's their job to tell everybody else, not mine. I need to know about it, but I need to hold that. And I think that discretion, so communication, visibility, accessibility, and discretion are key to keeping faculty confidence in your leadership. And I have open office time. I leave my door open all the time. My assistant understands completely. Any faculty that wants to see me, we find a slot as fast as we can. There's still the faculty who would rather talk to the prior chair than to me. So, you have to deal with that. I suspect Ron had a little bit of that in the first year or so that Ron stepped down and Brian took over up there because he's so trustworthy. But, you work your way through those kind of things.
I'm going to pivot. Oh, sorry. Go ahead.
Well, I was going to say, I recently reviewed a department that, whose resident ACGME evaluations had gone down some. And it was really interesting. And I think I think the big part of the cause is, as we all remember when we were residents and going into the residency office and having the support of the residency coordinator and staff that were there. And, they would have candy there and they would be a sympathetic ear. In many, if not most places, they're working from home. That's a huge loss if it all falls to the program director to be there. So that, we're actually looking at, our chancellor's looking at starting to mandate, at least 2 days a week. And we're trying to encourage, because that's a big part of the support system. It's informal, but that's lost if they're on Zoom. It's just not going to happen. And so, Zoom is a valuable tool, but you can't replace some of the things, particularly support that's in person, the casual conversation in the hallway or wherever it is in the lounge. Of course, we all pretty much came to work every day of the pandemic, but the staff didn't. And right. Don't underestimate their importance. And so now really trying to encourage them to come in. But of course, there can be equity issues. I mean, we have 2-3 staff that have moved to the East Coast, and it may be that we may lose them, and that's sort of a risk benefit thing. They're very talented, but it might be that we just need to have people back to support each other.
It's a lot of stuff to juggle. Go ahead.
No, I was just going to follow up, and for the people working in the operating room, the trainees and the faculty, those casual interactions are absolutely critical. Unlike everyone nowadays got trained with medicine really being a team effort out on the wards, etc. And then they come and in the operating room, in many ways, you're truly isolated. You may have some discussions and things, but it's not at all the same thing. And people very much miss those kind of casual social interactions. And as a department chair, you need to figure out how to design that into the regular workflow of the department. Things like providing food for people to get together for different events, and for many people, that's a critical aspect of what they enjoy about work.
It keeps people there. I wanted to try to take a tangent and talk about our allies and collaborators, because it sounds like I think Dr. Applegate uses the term boots on the ground. Somebody else might have done that. But, the boots on the ground anesthesiologist, the resident, the workplace could be quite adversarial. It's a matter of, oh, you are making me admit this patient. You're making me do one more case, whatever. But it almost sounds like in the way various clinical departments are interacting with the healthcare system, that we very much need to be collaborators and allies. And I was hoping to get the three of you to shed a little bit of light into that aspect of your tasks.
So you sort of mentioned two different things, and so briefly comment on both of them. One of them was the adversarial nature of some interactions. I think that gets into professionalism. And as a department chair, you need to basically be absolute about both maintaining professionalism within your department, and when you are aware of people with behavioral interactions that are not professional or not doing the job they're supposed to do, etc., you need to ideally discreetly, but you need to make that really, this is the way our department runs. If you're going to be here, these are the expectations that you need to follow. And you need to, again, you're not just an anesthesia chair, you're a healthcare system leader. You need to play a role in being sure that the entire system acts that way. So when you are aware of adversarial interactions of someone else to your anesthesiologist, that is getting followed through, and that often can be a discussion with the department chair to be sure that they're aware of it and that they will follow up, and that the institution has that. The other part you mentioned was allies, the positive side of interactions. It should be really easy because we pretty much are sharing the same goals. I mean, everyone here wants outstanding patient care. They want to see success. They want everyone to be happy. They want things to run efficiently. It can sometimes be challenging because not only are we allies, but we also often are competitors in different ways. I mean, what's ideal for one department may not be the ideal situation for another. It really helps to have those relationships with the chairs of other departments. At Stanford, every month, the clinical chairs have dinner together, and that's been great. They have multiple meetings together. You also want to have that sort of relationship with the medical director of the operating room, whoever ends up in charge of the interventional platform and its budget. And those are really, for allies, it depends upon having that sort of personal relationship, have conversations with them about what's going on in their life, their family, etc., and being sure that that there's synergy in the decisions you make, with the goals of the other departments and with the institution.
Yeah, I agree with Ron. I think one of the difficult transitions that happens when you become a chair is that you can't sort of have the same buddies, friends that you had as a faculty member. I was in critical care, and we would go out and do stuff together. But if you do that as a chair, you're viewed as having favorites. And the new set of allies, as Justice Ron said, are the other chairs. And I would say in particular, for example, I'm very closely aligned with our radiology chair. And the reason is we are both, people call them hospital-based. I like to call them core clinical services that are expected to provide, coverage 24/7. We have very similar demands, a lot of huge growth expectations, a similar payment model. And so, and I think, much as many of us had to, just a few years ago when the private equity market was coming in and salaries were skyrocketing. If you alone have to go to your CEO, CFO, and try to explain anesthesia, and I think one of my other mentors, Kevin Tremper, said to me, hospital administration doesn't understand anesthesia. That remains true to this day. But the surgery chairs do, and regardless if you have some closer and some less close relationships, but they actually made the argument for me that anesthesia needed to get paid more for what it did. That's very different than when I say it, because it's just viewed as self-interest. And so that's a good example of, you have to be well connected with your other chairs. And I'll actually say one of the really fun things of being chairs has been building those relationships. We also have a sort of a quarterly dinner, and then we have a separate dinner for the hospital-based or department chairs, because of those unique demands. And going back to the very first topic about how we get paid, no one comes to UCSF for anesthesia. They come for neurosurgery, orthopedic surgery, whatever it is. We have no control over payer mix. We can anesthetize, the payer mix that we receive from the other departments. And so, but anyway, I've really enjoyed getting to know them. We have, in all our institutions, spectacular people that are the chairs, and actually learning what goes on in those departments. But, those are critical allies, are the other chairs, and even more so a few of them. And so, and that's, part of being an effective chair is that, if they are speaking for anesthesia, if it's always just you that is trying to get resources, I think it's easier to discount it. But when, the surgery chair, we're expanding the surgery chairs, we must have, our colleagues in anesthesia. It's, some irony to it. You don't feel that every day when you're working with them in the operating room, but when they're asked to go to some strange land, they absolutely want you as their security blanket. So, leveraging those things is key.
Yeah, I could completely agree. And I think that there are several points to it. The necessity of not showing favoritism is very hard. You have the people that you work with most routinely, and as chair, you can't be seen to have favorites. So that's why the chair groups are so important, whether it's the UC Davis Council of Chairs, our hospital-based, caucus or subgroup, because again, those core services are foundational to the success of everybody else and do have very similar things. While I can't really add to that, I do want to clarify one thing. Although we don't get credit for it, patients, for example, come for our MRI scans under anesthesia because the other hospitals say, I can't afford to put an anesthesiologist there. You go over to Loma Linda or UC Davis or UC San Francisco or Stanford. When you get booted out of the local GI suites because you're too high risk from the literally mile away surgery centers that won't take care of you because you're too high risk, you actually are coming here for anesthesia. We just don't get the credit for it. So I think that's one of the things that, again, that's that education and substantiation part, so that your surgical colleagues, your interventional colleagues, whether that's pulmonary, GI medicine, whether it's the pediatric hemo-oncology or the interventional radiologists, go and say, no, you need to understand, they're here for us, yes, but they're here for us because our anesthesiologists can take care of these patients. A huge difference than it, as Michael said so eloquently. When I'm just standing down there, hat in hand, please, sir, may I have some more? That doesn't go very far. When your colleagues stand up and say, no, that's why we get this business, it really goes a long way. So I think, and I do also want to pivot back to one other thing, and I think Ron underscored it so perfectly. The expectation of professional behavior, I'm a very big believer in expectations, both for my own faculty and trainees, but also for those in other departments. And as was highlighted, you have to have those relationships with the other chairs. So you can say, this is not a professional way to interact. We are training the physicians of the future here. And frankly, it's just not nice to the people around you. So you need to talk to your faculty member and set out some expectations for them. Very big believer in that kind of both relationship and expectation setting.
I'm going to try to redirect this conversation back to the evolving nature of being a chair. And what I'm really curious about is, what would you consider your mission statement to be as a chair? What is it at this current moment? And is that the same or different compared to when you were, interviewing and looking for your job as a chair? And how do you anticipate that changing even further?
So I think I'm supposed to go first. I think in many ways the mission statement of a chair has not changed over time. In many ways, it's really several fold. One is to help the department achieve its missions, and we all have essentially the same missions. It's to provide outstanding clinical care and service, to educate trainees, to advance knowledge through scholarship, research, and dissemination, and it's to have leadership at the local and national level. The other, and that all of those are pretty obvious, and that's what you're hired to do. I think the other important thing, we've touched on it, is the real mission of a chair is to develop faculty and to have them becoming successful. In all of those missions, different people may have different ones that they focus on, but you want to see their careers progressing, they're getting increased recognition, doing more, etc. So that's always been, in many ways, the job of a chair. What also nowadays gets added is the financial aspects, to see the department actually able to afford to do all of those things and to contribute to the healthcare system. What's really, I'd say, changed over time is the relative work that each of those things involves. And as we talked about before, whereas at one point the chair took a more direct role in each of those areas, now there's much more of basically managing people who each have those individual roles. Your vice chair for education, for research, for clinical affairs. Most of us now have, a vice chair for faculty development, as mentioned, DEI, global health, etc. And how you achieve the mission has changed, but your mission itself has not.
Yeah, well, that's well said, and really nothing to add. I think an explicit goal of health equity and all that encompasses is around, whether that's in terms of the global health work that we do, but also in terms of the DEI work that we do, and examining how we do patient care and making sure that it's equitable. I think that's different. That definitely is not something I had in mind when I started. Maybe I did, but it wasn't explicit. It needs to be explicit. It's an expectation that it is now, and that resources are put into that. And then also that resources are put into thinking about the well-being of the members of the department. And that is also an expectation that didn't exist before. And I think those are all good things. But yeah, so I don't think that the mission statement has changed. I think the way that you achieve those things has really changed. I think, as Ron eloquently said.
Yeah, and I would agree. You asked, has it changed from when I first took on the role of chair? No, not really. With the differences in how you reach them. So we all want to lead provision of the best patient care possible in the safest manner as possible. We focus very much on what can we do that'll help our patients return to the optimum function as rapidly as they are able. We have to practice in efficient manners now. As you've heard, the financial burden is real. But especially agree we have to foster and mentor or coach, whichever term you like, development of clinical, scholarly, academic, and research in our specialty. We have seen in the decades I've been in practice shocking changes in patient safety. It is so much better. We used to quote a scary number for the risk of dying from your anesthetic from a misadventure when I was a resident. It was scary to us, admittedly. I'm married to a cardiologist, so, low risk is 1 in 100, which we would never accept in anesthesiology. But order of magnitude, 2 orders of magnitude, in some instances, 3 orders of magnitude safer than it was. I hope that continues over the next few decades, but that requires those who we're training to take up that mantle and to push the things forward. Could not agree more about equity and diversity. It's a very interesting thing when you look at who's on academic faculties. We are making conscious efforts to hire, and yet we're competing for the same, 12 or 15 graduates a year in some underrepresented categories. Because they're not choosing to even apply in some cases, or if they do apply, they're not matching to residency, so they cannot be in the pipeline for us to hire as academic faculty. So our work has to extend earlier. It really is a pipeline job. We've got to get people to see that what we do really does matter. And it turns out, still very much believe it, my lowest stress, my most fun day, OR days. It's the most fun you can have in medicine. In my opinion. My cardiologist wife does not agree, but I think I'm right. It's the most fun you can have in medicine. So we got to get people interested in it early enough that they can see, and then we have to support them correctly. Imagine if you're suffering microaggressions every day, Ludwig, you can just imagine if I'm seeing that across my operating suites, that every anesthesiologist is treated just slightly less than the guys that sweep and mop the floors. Why would I want to go into that specialty? Right. So we do have to work on that part of what we do too. We're not just there to raise and lower the bed and empty the Foley bag. Right. We do a lot of medical decision making that makes big differences in how fast those patients return to optimum function. I think that part of our message is not being well delivered yet. I think we have to do better on that part.
I think one of the things that I've really learned is that there's a lot of talented people out there, but we need to capture them, and I think that's what you and Michael just said. The DEI aspects, the well-being. Let's grab the people who are really good. I might have interrupted one of you. I'm so sorry.
Yeah. No, I was just going to add in terms of sort of mission. One thing I would add is anesthesiology in the next 5-10 years is going to undergo some very, very major changes. Everything from AI to the role of private equity, and the job itself is going to change. And I think an important role of the chair is to both prepare your faculty for what the changes are going to be, but also to play a leadership role nationally. The chairs, in many ways, are responsible for what occurs as anesthesiology evolves, to play a role in directing how the field evolves over time, so that it will remain a great career for all the people who want to go into it.
Thank you. Well, we do need to eventually wrap up this conversation. I feel like I could go on for like another hour. I wanted to delve just really quickly into something personal. If each one of you could share with me some of the surprises that you encountered during your careers as chairs, both the pleasant ones and not so pleasant ones, I guess.
So I'll take sort of 2 anecdotes. One of them is related to something we talked about before, which was, I became chair in 1999, and that was right after the mid-1990s, when we had no one going to anesthesia residency across the country, because they thought there was going to be a huge shortage of anesthesiologists. And by 2000, we were not graduating the number of people we needed. There was a huge, we thought there would be an excess of anesthesiologists. It turned out to be, at that point now, a huge shortage. Somewhat similar today. the salaries were skyrocketing, and private practice was hiring all the faculty from the academic departments. And we had some people from our faculty do that. Departments were smaller then, and we were very close to not being able to staff the ORs and get into that cycle of you don't have enough people, which means you have to have everyone spend more time in the OR, which means they have no academic reason to stay and they leave. And saw that occurred disastrously in many other departments. The chair of surgery and several other surgical leaders went to the dean, unknown to me, and told the dean, you have to solve this for the anesthesia department. They need more support than you're giving them. And that was really a very positive thing, knowing that you could rely on the other people you were working with to actually really look out for your welfare. And that's something which has remained throughout my entire time as chair. Sometimes it was people looking out for our department, sometimes us looking out for others, but that you really were part of a larger group that shared similar ideals. The other really surprising part to me, again, a bit similar to as physicians, the first few times it's really amazing how people, your patients come to you and they reveal just these really intimate details of their life to you, and it's in many ways a privilege and a responsibility. The same very much is true of your relationship to your faculty, to your trainees, to your administrative staff, how they will come and really trust you and ideally allow you to help them solve their issues.
Yeah, I think similarly, I think what surprised me was how positive the relationship building with the other chairs was. Because I think as a faculty member, you just don't know them and you don't view them that way. And, like I think I mentioned earlier, like Ron, I mean, they were really the people that advocated for more support for our department. There's a piece of self-interest in that, and that's fine. But I have really genuine friendships with not only the chairs, other chairs, at UCSF, but actually across the country. And that's actually been really rewarding. I think some of the, I don't want to, say anything negative, but, and part of this is, has to be your own growth of not, when faculty do behave in a way that's selfish or something like that, it can be surprising that someone would want to do that. But at the same time, I think, and it's very difficult when you start out. You're sleepless nights. You don't know how to deal with this. How are you going to have a difficult conversation with them? But that's no different than learning how to do a fiber optic intubation, right? You have to learn how to have the difficult conversation with a faculty member. And there's two parts of it. One is, what does that conversation look like? But the other part is, how do you manage it yourself? And now I just view that. I mean, I used to dread those and I'd see it on my calendar, and now it's like, okay, I'll do that. And you do it and I move on. If you can't develop that, I mean, I call it a thick skin. It's maybe that's part of it, but maybe that's a little bit too simplistic, but you have to do self-care. You have to take, it's such a hard job. It's almost 24/7 in some ways. It certainly is emotionally, psychologically 24/7. So you have to figure out a way, to take the time that you need to exercise, to spend time with your family. And in fact, letting your faculty know that you're doing that, because, hopefully there are people in your faculty that want to be a chair someday. And if they just assume that the only way you can be successful in that is to work 24/7, it's a problem. And so, when I started, I remember I never used to put an out of office reply on my email, but my boss does when he's away for a long weekend. And I'm thinking like, oh, okay, I really admire him. I'll do that too. And so letting people know but there's just many parts to doing, the self-care that you need to be effective, and don't apologize for it.
I have to say that the most pleasant surprise has just been remarkably illustrated, and that is that the other chairs are good examples of what can be done and also are struggling with the same things that each of us does. Yes, it's my 8th year of being a chair, but there are still nights when I know the first meeting in the morning tomorrow is going to be a challenge. I have to be sure I have my educational points all lined up and then I'm ready, and I'll wake up, 3:34, and your mind does not go back to sleep. You have to learn how to turn that off, and especially not take it home, because your family knows when you're worked up. Don't pretend otherwise. They know. So the pleasant surprise is how supportive the other chairs are, both in anesthesiology across our region, but even most of the chairs who work with you closely in other departments in our surgery and interventional. I would say my biggest not so pleasant surprise is that there are still pockets of people that do not understand why physician leadership adds value to anesthesia care, right? We have made it so safe. Now, anybody with a good algorithm, an iPad, tablet computer, and, at least a little bit of ability to start an IV, anybody can do an anesthetic now, right? And this lack of understanding of the value physician leadership adds in anesthesia, perioperative care, peri-procedural care, I think is one of our biggest challenges right now. And I remain surprised. It's not unique to, UC Davis. It's not unique to Loma Linda. I saw it both places. There is that pocket who believes, now that it's so safe, let me find the cheapest way to do this. And I think that we have got to do a better job explaining that. And this is even you read the news, legislators, read Becker's, look at the little blurbs from Medscape, big anesthesia shortage, 7% deficit according to HRSA, probably more like 10 or 11% according to the recruiting firms. If you look at how many open positions there are and how many people are really looking, with a growing alternative provider workforce that's expected to exceed the demand under current staffing assumptions in the next 10 years. Why keep a doctor around if I can have somebody else do it just as safe, but for less? It's all about the bottom line, because dollar is king. And those two surprising things, those were the disappointments. When you're not the chair, you think that, oh, well, everybody understands and respects what we do because they all respect Dr. Gropper. They all respect Dr. Pearl, right? But in fact, there are a lot of people who don't think that we add that much value. So I think that we're disadvantaged in that. I think that if we're now on a CSA thing, I'm going to give the advertisement for CSA. We need every physician anesthesiologist in California to be a member, to have the voice that we need. And I don't care if you work in a system that is never going to let you do anything different. Just the number on the ballot count makes a huge difference when you go to Sacramento. I will say that was one of the pleasant surprises I found when I was in Davis, a few miles from the Capitol building. You learn a lot more about the real inner workings and how these people really think when you can pop over there and listen to them. So that was also an interesting educational point. So that's my advertisement for CSA. I know that my colleagues on the call share that opinion. Membership matters. Even if you're never going to go to the legislative day, even if you're never going to click on the submit letter here, just that number in our team that is in the society makes a huge difference at the legislative offices. The legislative aides actually do those counts. How many members do they have? That's not very many. So we've got to do a better job on that too. So that's my advertisement. I'll stop.
Sounds good. Just sounds like a lot of work. This 24/7 thing sounds pretty on point to me. I feel like there's so much more to cover about, for example, the different healthcare workers within anesthesia, more about well-being, more about sustainability. I will just have to invite all of you guys back for another conversation. But let me put a stop to this conversation now. I really appreciate all three of you taking the time to do this. I think this has been very illuminating. Hopefully for the younger generations of anesthesiologists listening to this is going to be inspiring. It's going to be a call to arms to be more engaged, to start being engaged, to aspire to be a leader, to be an ally, all of that. So this has been another episode for the Vital Times podcast series for the CSA. Thank you for listening, and have a good day. Cheers.